showed up. You know, depending how many diagnostic procedures they would do, you know, X-ray, MRI, that could, you know, be quite a lot. He also, you know, would have PT anywhere from 10 visits, 20 visits, depending on what that is. It's an awful lot to take care of. And I'll show you some of his actual data in a second. So what he's gone to is kind of what I would call a virtual first approach, right? So 85+% of his patients are perfectly happy. Obviously they recovered just fine. So what he does on what I would call the top arm up here is he sees everybody at 2 weeks because he wants to look at the wound. It's his first chance to talk to the patient, so you know he wants to have that visit. But after that, they just kind of see how it goes. So if they're okay, if their activity levels and the range of motion's fine at 1 month or whatever, they just do a virtual visit. His nurse does the call, they call, talk to the patient, and then they just continue on. And if the patient continues to do well, they do it virtually from that point forward. Patients actually love it because somebody takes the time to call them up at home to see how they're doing. They actually feel better cared for than otherwise. On the other hand, and I'll show you some of his data, you know, if, you know, somewhere between week 2 and 3 months the patient goes off course, they bring that patient back in, or they do a virtual visit together. They don't wait for the 3-month visit for the patient if they feel they're going off course. So for the 15% of patients that aren't doing well, they try to identify them early and they try to intervene more aggressively on that. His practice, he loses 50% of his patients to follow-up. So, you know, even with all that work, he was still only screening half of his patients. He's now at, you know, 95, 96% follow-up on his patients. So that's good for the practice. Jeff Yergler, who's in South Bend, Indiana, Jeff loses 90% of his patients to follow-up. So this is the first chance he's really had to follow his patients because, you know, it's quite a rural practice, and you know, people drive 4 or 5 hours to have their surgery and never come back. So that's fine. So these are a couple of Charlie's case studies. So this is probably the type of person you wouldn't think you'd want to put the knee in, but he actually finds it fairly useful. So this is one of your super achievers, the 25% who are doing really, really well. He finds this quite useful. A lot of people come in and say, hey, is this normal? Is that normal? You know, end up doing extra diagnostic procedures, extra visits on people who are actually doing really, really well, just because they need that kind of reassurance. Now they can get on the phone and say, hey, look, your activity levels are off the charts, your range of motion's in the 95th percentile, you know, and the patient calms down, everybody calms down, and they're able to manage that kind of 25, 30%, you know, who have very high expectations without a lot of intervention. But this is the stuff that's kind of cool. So this is a patient, and you can see they start to decline at, you know, between 3 and 4 weeks. So this would happen, you know, during that period where there was no scheduled follow-up. Call the patient. Patient says, no, I'm doing great. I don't need, you know, I feel great. He said, but, you know, your numbers don't look great. So they changed the PT, brought the patient back in, do a little bit of massage, change PT, change the compression stockings, and, you know, within 3-4 weeks, patient's right back up to normal. This is kind of a graphic representation of that. This is a patient they brought back in, you know, 2-3 weeks after surgery, sudden precipitous drop-off in performance. They make a couple of changes, some mild mobilization, they modify the exercises, and by, you know, week 5, you know, they're back to where they need to be. Would this patient have needed manipulation? I don't know. Probably not. A lot of people, you know, recover just fine, but it allows them to kind of tailor the response to where they're at, and it's certainly you know, something that they're starting to use for kind of early identification of the people that are tailing off. They're kind of so comfortable with it right now that they will get their patients to take a video and send it in. We were talking before about, we diagnosed our first stroke the other day. We had a patient whose gait dramatically changed. We had the partner take a video. It was like, oh, it's a hemiparesis. That's why your gait has changed. And you know, we're starting to see some interesting things. But they will just have them take cell phone videos instead of the other visits. And they're doing a lot of this kind of virtually now, where they'll just bring, they'll see this, they'll do the intervention over the phone, change the videos, or excuse me, change the physio or PT. You can tell I'm Canadian. Change the PT and maybe modify their exercise. So where we're going with this is that we all live in this world where it's very joint centric, and we think about it. We pulled 1.4 million Medicare records to look at the cost of TKA. And probably to no one's surprise, everybody understands this cost really well. What they're paying you guys and what they're paying the joint manufacturers, that's really well understood and in everybody's laser focus. But they spend about $5 billion a year on the devices, but they spend $10 billion a year on follow-up. It's about $10,000 per patient in follow-up every year. We've started to look at it. I now have some really sophisticated data, actually, in terms of what it's being spent on. But as you can appreciate, it's a whole bunch of different things. It's home health, it's revisions, it's ER visits, it's MUAs, it's infections. It's like a grab bag of all kinds of stuff. About $5,000 of that is spent in the first 90 days, and the other $5,000 is spent in days 91 to days 365. Heavily skewed, probably to no one in this room's surprise, towards a small number of very expensive interventions. But it's also amazing how many patients are lost to follow-up who never are seen again. Any takers on what the spend is in year 2? That was the stat that surprised me. I thought it would be really low. It's actually $6,000. I have no idea why. I haven't gone through the data yet, but my gut tells me that all those patients that are lost to follow-up re-enter the system in year 2. But the cost in year 2 is much higher than I expected. So what can we do about that? So I promised I'd get some interventional cardiology in here somewhere. So what I'm going to show you, hoping this runs. So this is the actual data. So that's an X, Y, and Z gyroscope. That's an X, Y, and Z accelerometer. So conceptually, this is like an ECG. So an ECG is 12 views of an electrical wave. What you're looking at is 6 views of a motion wave. But everything you do with that wave is analogous from that point forward. So the deep neural network that worked at ECG was the human brain over 50 years. But you guys are too young, but when guys like me went to medical school, you actually had the calipers and you'd measure out all the different intervals to calculate what everything was. And so the easiest way to describe it is I'll say, look, I think with enough patients, we're going to be able to diagnose infection, we're going to be able to diagnose DVT, we're going to be able to diagnose risk of hospital readmission. People say, well, how can you do that? You don't have temperature, you don't have pH. Well, you can diagnose myocarditis off of an ECG. You can diagnose ischemia, you can diagnose valvular heart disease. None of those are electrical events. And the reason is that an abnormal heart beats differently than a regular heart does, and it does it in a reproducible way. And when you have enough views of it, you recognize that. So I don't know why you get ST elevation, but I know what to do when I see ST elevation as to what that patient might have and how I might manage it. And if you think about gait, what we have here is actually not an ECG. We have a Holter monitor that's cemented in place, and we're looking at the gait of one human being from 7 in the morning till 10 o'clock at night. So even relatively subtle changes are going to be detectable with enough mathematics and enough computing power. And so the concept is that if you have a DVT, you'll probably walk slightly differently than if you don't. If you have an evolving infection, you're probably going to walk differently than if you don't. If you're at risk of readmission, you probably will as well. I ended up practicing emergency medicine while I was doing my first company, and we all do it. You walk somebody walking in, you're like, that's a cardiac gait, right? That's an asthmatic gait. There are, changes with everything that you see. I'm actually kind of excited at looking for things like Alzheimer's and early Parkinson's and MS and all kinds of crazy things based on gait changes. So common things occur commonly. The two things that we've done so far, we've been able to look at contracture, because that's the most common problem. So we're almost have a diagnostic for that. And we have a pretty good idea about loosening. When you have that implant in, it acts like a tuning fork. So every time the heel hits the ground, you're pinging the tuning fork. And you're going to get a different frequency if it's loose than if it's tight. And so for an implant that's loose, we see a vibration pattern at 6 to 8 hertz that we never see. And so it's kind of an early indicator of the degree of loosening. We haven't done cementless yet, but I'm actually very interested to look at the opposite happening, which is starting with loosening and osseointegration and how that changes with time. So this is in front of the FDA right now. It'll be our first diagnostic. If you're in the 90th percentile, your chances of having stiffness or needing a manipulation are essentially zero. If you're in the bottom 5-10 percentile, you have about an 11-fold increased risk of that complication. So this will be kind of our first early warning, check engine light that will be on the dashboard that will be an indicator of things that will come. But in the future, I hope to have one for everything as we go along. So what you're looking at now is the first deep neural network that we've done. This was done in Zach Kahani's lab at Harvard, Department of Bioinformatics. He's on our board and one of our data scientists. On the left is the patient's actuals. On the right is the computer predicting the next 2 to 3 weeks of what their data is going to be. Those of you who have experience with CGM will know that now we don't just look at CGM, it now predicts what the next 12 hours are going to look like based on the pattern that comes. That's what we're trying to do right now with kind of key metrics. So why does that matter? So this is data we presented at AUKUS. It's really simple stuff, and will be a surprise to no one, but these are the actual numbers. So what are you looking at? So this is where a patient starts, and this is where they finish. So 3% of people have terrible kinematics and terrible activity levels, and they finish off with terrible kinematics and terrible activity levels. About 34% of people are normal. They start off with normal metrics, they finish with normal metrics, right? Your overachievers are over here in this category. To no physician's surprise, patients can follow any recovery pattern possible. These are just what the numbers are. A couple things that stand out that I think are really interesting. If you start low, you actually have a better chance of ending up normal. So 5% of people start low and end up perfectly normal. 4% of people start low and end up with actually really great results. So if you start low, you actually have 3 times a better chance of ending up okay than you do of ending up poorly. Conversely, if you start high, you actually have a much higher chance of ending up with a bad result at the end. And what I also think is fascinating, if you look at all the lows and you add them up, the 3, 12, 6, you get 21%. We've been saying for 50 years that 20% of people are unhappy with their TKAs. I don't think it's going to be a perfect overlap, but one would imagine that if you had poor kinematics and poor range of motion, there'd be a higher probability you're unhappy with your result. But that's what the numbers are. So my last slide, so when you put those things together, this is where we'd like to go. So this is, patient on the left is a start crappy, stay crappy type patient and is not going to get better. The patient on the right is a patient who starts poorly and ends up actually perfectly normal. And what I think is fascinating is the algorithm is always predicting the patient on the right is going to improve. So, in a perfect world, 100,000 patients from now, patient on the left might be somebody you were more aggressive intervening on because they're not looking like they're following a good trajectory. Patient on the right is a patient who looks like they're going to spontaneously resolve. You might have more supportive care. So the goal here is to use this all to give you guys, I call it CGM for orthopedic surgery, is to give you guys some sort of indicator of how people are going, where they are on their recovery pathway. And whenever we have residents, I always say the same thing. Somewhere in this room is like the first perfectly digital orthopedic surgeon, right? If you use robotics to put in your device, and if you have kinematics that you follow up with, you will have a living record of your statistics of every patient you have and how they recover and what pathway they went and what surgery you used for each one. So the last thing that we're trying to do is incorporate this with robotics and other things to see if, you know, subtle changes in how you do things in certain patients results in measurable differences at the end of the day. So that is what we're up to. There is a ton of work to be done, but it's pretty fascinating because the data set is a lot of fun to work with, and we're learning a lot every day. So I'll stop, and if anyone has any questions, I'm happy to answer. Awesome. Well, thank you.
Question.
Yeah.
So if you look at the functional range of motion and then how that correlates to range of motion that we see in the office. Right?
Yeah.
I've got patients who have terrible range of motion.
Yep.
Yet if you watch them walk, they don't look that bad.
Exactly.
When they're trying to do other activities.
Yeah. Well, obviously in the wild, people don't do the full range of motion. So what we do have, we have a couple of devices that we built. We have a wearable, which you saw, so that you can do a preoperative and postoperative assessment. But we also have what we call a doctor's office base station that is kind of like an event recorder in interventional cardiology. So if you have a patient who has a particular problem, you can press the button on that device and it will light up the device and put it in maximum mode. So it'll do those 800 observations per second. So, you know, while you're doing your physical exam, you can actually be recording what's going on inside the knee at the same time you're doing an exam. Or for example, if you have a patient who says, I only have pain, you know, I have pain when I'm getting out of a chair or I'm going upstairs, you can actually have them do that, and you can look at how the joint's responding relative to what they're saying subjectively. So we built a tool to allow you to do the measurement internally at the same time you're doing it externally. We don't have enough data to correlate that perfectly yet, but I'm hoping if we get enough clinical exams versus functional range of motion, we'll start to have an idea of how functional range of motion correlates to absolute range of motion. We don't have enough data yet.
Along those lines, do you have any sense of how many ECGs it took to say ST elevations back? Here's what we do with it? Like, you know, we're obviously in data collection mode right
Yes.
now, right?
Yep.
And you're starting to do some great things with
Yep.
how do we interpret that?
Yep.
Like, is this a 1-year path, 5-year path? Like, you know, at what point
Yep.
does data collection continue,
Yep.
but now
Yep.
we're really getting to act on it?
So I'm going to answer like this, like I know the answer, when it's guys like him who do. But the way it's been explained to me is we need probably around 100 or more complications, right? And so, for example, if just for argument's sake, let's say we had 200 infections, right? What we would do is we would go and we would train an algorithm on 100 of those infections. So we'd look at the data pattern from all these normals, and then we'd look at the data pattern from 100 people who had an infection, and you know, the algorithm would look for the ST elevation equivalent. It would look for what was different in those two data sets. We may never know what it is, but it will look for the difference between those. Then we would then take the computer and have it look at the entire data set and see if it can find the other 100. If it finds 90 of them, it's 90% accurate. If it finds, you know, 80 of them, it's 80% accurate, but that's how we would do it. So we need enough data. So to get 200 infections at a 1% infection rate, you know, you're talking about 20,000 patients, but we'd actually need them to be reported to us for us to do the MR. So in the real world, we probably will need 50 to 100,000 patients before we can do all of that. But one of the reasons we partnered with Zimmer is they put in several 100,000 knees every year, so it should be mathematically possible to do it in a relatively short period of time.
And just to add to that, so we already have these curves available to all of you who are implanting PIQ. It's on our website, cantorio.com. You log in with your MyMobility credentials. For Dr. DeCook's office, Bill showed a couple of those recovery curves where you see low performance initially, and then some other intervention that was remotely triggered, and then the upward trajectory. So we don't have the FDA claim language that would go behind what Bill just described, but as a user of this descriptive data that's being objectively generated from within the patient's knees, you have the ability to use that to take action and get results like what you've seen.
I mean,
right now.
our docs do think they're preventing contractures. They do think they're starting to recognize at-risk patients earlier and intervene earlier.
Sorry, so are you guys capturing what those interventions are, right? So like, I always think about when I'm in the OR and the anesthesiologist puts the A line in, I'm like, okay, great, we know what's going on, but
Right.
there's some ability then to interact on that, right? And,
Yeah.
and what's it actually providing so that you can change the course of the future,
Yeah, it's
Yep.
been really interesting, like,
as opposed to just knowing what's going on.
Yep.
yeah, like, for example, in physical therapy, I didn't know like certain stretches are necessary just to encourage patients who have full range of motion, but when they walk, they don't bend their knee much. And it's like fear-based. And so if I'm not a physical therapist, but certain stretches encourage patients to walk with a normal gait, and you see that improvement. And I guess that would improve patient outcomes, I guess, and also possibly prevent other issues from repeatedly walking with a halting gait.
But the truth is, right, I mean, we went to friends and family and said, we don't even know what this is going to show. Like, we need thousands of patients before we can actually do something. We're in the thousands now, and now we can tell normal from abnormal. We're starting to be able to see some clinical indicators. My hope is that, a year from now, 2 years from now, with a bigger, more comprehensive data set, most of this stuff, we already know theoretically it works. Like, we can see it in the small numbers. We don't have big enough numbers yet to do it in a meaningful way. One of my pet research projects is we have that wearable. And so we're taking people with recognized abnormalities. So, a loose implant, a fractured patella, a DVT, whatever complication, and we're putting the wearable on it, and we're just seeing what the gait pattern is, so that we can start to figure out what the abnormal gait patterns are, so that we can look for it in the wild. So we're trying to hack our own system to accelerate that. It's suffice to say, when somebody's got an infected joint, the gait pattern is dramatically different. But we'll need a big enough data set to be able, because that doesn't help you when the implant's already contaminated. The goal would be to see that 2 weeks in advance, where you could actually do something meaningful about it. But that's going to take probably another year.
I have an operational question, and maybe